Zoll Life Vest is a proud sponsor of CardioNerds. Zoll has continuously improved Life Vest for over 20 years, leading to a median real-world wear time of 23.4 hours per day and an AI-enhanced algorithm that delivers zero median false alarms at 90 days. The newest Life Vest garment is lightweight, breathable, and preferred by patients for its comfort. Learn more at lifevestinnovation.com.
This programming is brought to you by Boehringer Ingelheim Pharmaceuticals Incorporated. Heart failure guideline-directed medical therapy offers an opportunity to provide better care for patients, but significant gaps in uptake remain. Now more than ever, it's time to pump up GDMT for heart failure. Leaders in the cardiology community recognize this need and are asking you to do the same. Visit pumpupgdmt.com to learn more. Together, we can help ensure guidelines are enacted and patients receive quality care.
Hi, everyone. My name is Pooja Prasad. I'm an advanced heart failure transplant cardiologist at UCSF, and I'm going to be hosting this episode today with Dan Ambinder. I've been a cardio nerd since my fellowship days, and it's an honor to be here with a group from Phoenix. We will be joined today by Harrison VanDolah, Shrishti Nayak, and Donny Mattia. Harris, Shrishti, and Donny, please introduce yourselves.
Hey guys, we're just so excited to be here on our favorite cardiology podcast. I know for me, CardioNerds has been so awesome and inspiring as a student and a resident and hopeful future cardiology fellow. My name's Harrison. I'm a Phoenix native. I was born and raised here in the Valley of the Sun. It's exciting to get to share some of the great parts of Phoenix with you guys all today. I went to a small liberal arts college in Minnesota called St. Olaf College for my undergrad, and then went to Creighton for medical school in Omaha, and then 2 years in Phoenix for my clinical training. And I've been here for MedPeds residency since then at the University of Arizona College of Medicine, Phoenix. My hopeful plans are to pursue adult congenital heart disease once I'm done with cardiology fellowship.
My name is Shri, or Shrishti, and I'm a third-year cardiology fellow at Mayo Clinic, Arizona. I was actually born in India, but I've been an Arizona native for 20 plus years, so this is definitely home. I did my residency training in medicine and pediatrics, just like Harrison, and I'm hoping to apply to ACHD fellowship in the future as well. Maybe we'll be co-fellows. I'm just so excited to be here today and just so honored to be part of this podcast.
Cool. So hi, I'm Donny. Super excited to join here today. I'm from Minnesota originally, where I did engineering at U of M for undergrad. And then made my way to Omaha, where I did med school at Creighton and did peds residency training here in Phoenix, where I stayed on for ped cardiology fellowship. And I'm currently a third year here.
Wow. Thank you so much for introducing yourselves. I'm so impressed by our representation here today on this podcast from both the medicine and ped sides of things. And I think that's going to make for a really interesting case. If you were to paint a picture for me of what's your favorite day and your favorite thing to do on a Sunday in Phoenix, what would that be?
Well, I'm so glad you asked, Pooja. I've got just the place in mind. We're going to start off with some exercise, a sunrise hike of Piestewa Peak, which is only about 10 minutes from our hospitals here right in the middle of Phoenix. Afterwards, we can grab a nice coffee, a pastry over at our favorite coffee shop in Old Town Scottsdale, which is well before the bachelorette parties will arrive, and head over to the Phoenix Botanical Gardens for a beautiful and thought-provoking stroll. And we can discuss two great cardiology cases that are full of pearls.
Oh my gosh, Harrison, Shri, and Donny, what an honor to be here. And I'm so pumped. This is like the perfect setting for us to talk about some great cardiologies. Pooja and I are just so happy to be here. The last time I saw Pooja in person was actually at ACC in New Orleans, and that was pretty fun. So I'm pretty confident we're going to be having a lot of fun today. So why don't you guys tell us about your case?
So our case comes as a consultation by the obstetrics team. They consult us for concern for peripartum cardiomyopathy. So me as your resident, I'm going to go see the patient, present the findings. So I see this patient. She's a 27-year-old female. She's G1, now P1. She has just delivered a healthy baby boy at about 34 weeks after going into premature labor. She delivered vaginally without complication and is now 1 day postpartum. She's now experiencing shortness of breath that's out of proportion for what they would expect postpartum, and she's requiring 3 liters of oxygen nasal cannula. Delving more into her history, the patient describes a notable past cardiac history. She says that she was diagnosed with atrial fibrillation and something called Wolff-Parkinson-White in her teenage years. She also has a pacemaker and an ICD, but she's not exactly sure why she had that placed. Unfortunately, she has just recently moved to Arizona, so we don't have any records available to review. Going into her family history, she notes that her sister has similar problems and that her mom had passed away at 28 years old after delivering her. She also had something wrong with her heart, but she's not sure what. For her social history, she identifies as African American in ancestry, and she recently moved here for her work. She does not and has not used any substances, is a never smoker, and rarely drinks alcohol. She reports good social support from her sister and the father of the baby, who are both living with her now, and she is planning to breastfeed.
So that was amazing. It was definitely an ID level history that you got there, Harrison. So definitely an interesting consult. There's a lot of features of her history that makes us very suspicious that there's more here than what we first might think of right away. But I definitely want to hear more about what she looks like on exam to help us decide where to go from here.
Absolutely. Her vital signs show normal temperature, 36.5 Celsius, heart rate 114 beats per minute, a normal blood pressure 128/80, and she's statting 96% on 3 liters of oxygen nasal cannula. For me, she was breathing comfortably, no acute distress. Her cardiac exam did show normal S1 and S2 with a faint S3 sound, and I didn't appreciate any murmurs. She did notably have an elevated JVP, about 6 centimeters above the clavicle. Her lower extremities had symmetric 3+ pitting edema going up to her thighs. She does have strong peripheral pulses and she is warm.
Okay, so to summarize, so what we have so far, we have a 27-year-old female with an unclear but seemingly quite significant cardiac history. She had a pacemaker and an ICD. She's currently showing signs of acute decompensated heart failure acutely in the postpartum period. Now, here we do need to rule out important life-threatening etiologies that we should always consider in this setting. So the main one would be pulmonary embolism, amniotic fluid embolism, or SCAD. Now, with our underlying cardiac history, we also need to consider an acute arrhythmia. But of course, this underlying heart failure exacerbation and this prolonged history, we also need to think about whether or not this heart failure is being caused by valvular disease or an underlying cardiomyopathy. We also have to think about why this might be acutely worsened in a peripartum period. But right now, it sounds like she's not in shock, so we have some time to think.
Well, it looks like our OB colleagues have already obtained a few things for us, which is great. We have some basic labs. We've got a CBC and a CMP, all of which looks normal. And they also ordered a high sensitivity troponin and a DIC panel that both are within normal ranges. They did order an NT-proBNP that was 600. Also obtained a chest x-ray, EKG, and a CT angiogram of the chest. Chest x-ray does show some bilateral interstitial pulmonary opacities that are consistent with pulmonary edema. Her EKG shows a AV paced rhythm, no ST elevations or evidence of acute arrhythmia. And her CT angio of the chest showed no pulmonary embolism.
That was a great job to our OB colleagues for obtaining a fantastic workup. At this point on our differential diagnosis, I think we can safely take pulmonary embolism and amniotic fluid embolism off the table. However, based on her EKG and troponin, I would say that we still have to consider ACS, although it would be lower on the differential. And at this point, in terms of ACS, I would still be a little bit worried about SCAD, so I would still follow her EKG serially. And I would make sure that she's not displaying signs of coronary vasospasms by monitoring her symptoms and making sure that her chest pain's not episodic and related to her blood pressure. So at this point, we have to really think about what is the etiology of this acute decompensated heart failure. Now, when our OB colleagues call us, I think it's very easy to anchor the consult on exactly what they're calling us about. At this point, it's a postpartum patient, so our immediate concern is going to be, is this a peripartum cardiomyopathy patient? Now, veterans of CardioNerds podcast will remember that fantastic Cardio OB series, I think specifically it was episode 113, where we talked about how peripartum cardiomyopathy is a diagnosis of exclusion, defined by the decrease in LV systolic function either during the last month of pregnancy or even up to 5 months postpartum. It is thought to be due to an abnormality in the way the heart responds to the prolactin surge that typically starts in the 3rd trimester and can continue into the 4th trimester of pregnancy or the postpartum period. Now, I just want to stress that even though this is a diagnosis of exclusion, the latest guidelines by the ACC and AHA state that we can treat this with bromocriptine, typically given for 7 or 14 days. So it's still an important diagnosis to think about while ruling out other more common causes. So based on our patient's particular cardiac and family history, I think it's a pretty strong marker that we've been dealing with some sort of underlying cardiomyopathy here, possibly due to a genetic cause. So I think it's time we turn to our favorite diagnostic modality.
Thank you so much, Shri, for bringing up all those great points when it comes to peripartum cardiomyopathy. I think that in this case, we knew that the patient had an ICD, so we knew that they had a prior history of heart failure. But what I found is really important is differentiating the history and when patients have onset of symptoms. As you bring up with peripartum cardiomyopathy, we have to think about the possibility that patients had a pre-existing heart failure that simply decompensated during pregnancy due to hemodynamic changes with pregnancy. So, great job thinking about the differential diagnosis and how important it is to exclude other causes besides peripartum cardiomyopathy. So, Harrison, why don't you go ahead and tell us about what diagnosis we did next?
Well, I thought you guys would never ask. It's time for our transthoracic echocardiogram. So our echo shows a severe dilated cardiomyopathy, left ventricular ejection fraction of 20%. There's also some concentric LV hypertrophy. Valvular function appears normal in the setting of the low ejection fraction. At this point, what are we thinking?
I think at this point, we've ruled out any kind of valvular dysfunction or congenital heart disease that might be causing this cardiomyopathy. And it sounds like there aren't any obvious signs of LV non-compaction or ARVC as well. Now, with the LV hypertrophy, it's possible that she had hypertensive heart disease, although it sounds like she doesn't have any significant pre-pregnancy history of this hypertension. Also, she's only 27, so she's very young to have this. Now, strain imaging can be somewhat helpful here. However, her LV function has already so diminished, it's already at 20%, that the strain numbers might be abnormal just because of that. But it's something to keep in mind for other patients whose LV function might be a little bit better. Now, at this point, we may need to do some more advanced imaging, such as a cardiac MRI, because I think we need to think about other diagnoses like hemochromatosis, HIV, and we may need to think about some genetic testing as well. Now, in the meantime, while we're thinking about the diagnosis, we also have to treat our patient. So we should get her diuresed with IV furosemide, being careful not to overdo it because there is also some natural diuresis that occurs post-pregnancy. You're losing about 25% of your blood volume, and she's trying to breastfeed. So we want to make sure that she has adequate fluid for the baby. Now, after a couple of days, she lets us know that she's feeling well and her baby's feeling well and she's just itching to go home. So prior to discharge, we initiate her on some guideline-directed medical therapy that's safe for breastfeeding, such as metoprolol tartrate, enalapril, and spironolactone. Of note, ARNIs and SGLT2s have yet to be studied in the postpartum period or breastfeeding women, so we've held off on these for now, but definitely something to consider even when she decides to stop breastfeeding. And we also discussed the importance of contraception, as we still don't really have a diagnosis. So for her, I would recommend a contraception that has no estrogen-containing products, given her severe LV dysfunction, so as to decrease her risk of thromboembolism. Now, I believe her and her OB team had decided on a progesterone IUD, and she heads home and plans for future workup in the clinic with titration of her GDMT.
I can't emphasize enough how important it is to think about contraception in this patient population. So I'm so happy that this wonderful team did such a good job of being thorough and making sure that this was addressed prior to discharge rather than leaving this in the outpatient team's hands. So Harrison, tell me what's been going on with her son.
Yeah, it's funny as a med ped resident, sometimes we go to another hospital across the way full of children. So I happened to be there working with my friend Donny down the street, and it turns out that her son is now being seen by our wonderful pediatric cardiology team there at Phoenix Children's. So Donny sends me in to see her and her son. So it's great to catch back up with her. She notes that the baby was referred for pediatric cardiology evaluation given the family history of cardiac disease. He is now 6 months old, he's growing and feeding well, and he's meeting all his developmental milestones without any concerns. His vital signs are normal for his age. Heart rate's 117 beats per minute, blood pressure is 106/55, and 96% on SATs on room air. His exam shows a calm and happy baby in mom's arms. He does have a 2 out of 6 systolic ejection murmur at the lower mid-sternal border. I don't palpate any hepatomegaly on him, and his femoral pulses are strong. We did already have a TPE available for us, which shows severe hypertrophic cardiomyopathy, to the point that there was an obstruction in the mid-cavity with a peak gradient of 59 millimeters of mercury.
Wow, now that is an impressive echo. I'm glad that he's doing so well with all that's going on there. For my adult colleagues, one thing that always impresses us in pediatric cardiology is how well kids can compensate for their heart failure. Clearly, this young man has severe hypertrophic cardiomyopathy. And listening back in episode 166, Dr. Michelle Kittleson mentioned some things that we look for. Typically, the first signs I look for are on the EKG, which would look for signs of left ventricular hypertrophy. So either having large R waves in your lateral leads or inverted T waves in D326. Let's review our differential diagnosis for the son now. Hypertrophic cardiomyopathy is approached by focusing on really two different categories. You have your sarcomeric mutations within the structure of the muscle itself, and then non-sarcomeric causes as well. One important difference in pediatrics is that infants are more likely to have non-sarcomeric causes of hypertrophy as opposed to our adults. So this category includes infiltrative diseases, which would be your glycogen storage diseases. We classically think of Pompe disease. It also includes mitochondrial mutations or a group called RASopathies, which are errors in the RAS-MAP kinase pathway, which regulates growth within our bodies. And one common example of that would be Noonan syndrome. Sarcomeric causes are usually within the muscle themselves, and the most common genes that we encounter would be the myosin heavy chain or myosin binding protein C. Sometimes there's a family history, as in our case, there's a pretty significant one, but often we don't have that. And if there's significant hypertrophy or any level of left ventricular outflow tract obstruction, we often end up sending a cardiomyopathy gene panel. The rest of our basic workup for cardiomyopathy would include an echocardiogram and a Holter monitor. And then if there's any significant hypertrophy or dysfunction, that's where an MRI can be helpful. In the setting of any cardiomyopathy, we typically get a baseline MRI around 10 years old anyways. This is the age when kids are able to do breath holding for us without needing anesthesia. The main reason for us doing an MRI is that any scarring can be seen due to ischemia, and that's detected by late gadolinium enhancement.
So as your eager resident in clinic, I want to get a cardiac MRI. Are you okay with that, Donnie?
Yeah, that sounds great.
So we get our cardiac MRI for him. It shows severe concentric hypertrophy and slight asymmetric thickening of the septum. Notably, there is diffuse late gadolinium enhancement that spares the ventricular septum. So me and the medical student that are with you today, since we've got all our free time, we start looking up some studies and we find some papers that are talking about this finding being seen in some patients with a genetic syndrome called Danon Disease. Should we test for this?
At this point, our differential diagnosis is really starting to sound more suspicious for an infiltrative cardiomyopathy, and Danon would certainly fit that criteria. It's hard to test for because numbers are small, but something that is definitely on our differential. So I agree. Let's send our gene panel for hypertrophic cardiomyopathy. We should also start them on a beta blocker at this point. The goal there is really to try and optimize its preload and shift us up that Frank-Starling curve to improve cardiac output. And then, of course, we'll follow him very closely. In the meantime, how is mom doing?
Yes, I'm back over with Shristi over in adult clinic. She does know that she's continuing to struggle with decompensated heart failure. She just got out of the hospital with a heart failure exacerbation. So the team has decided to send her for evaluation for heart transplant.
And during this heart transplant evaluation, based on the family history, we will typically offer some form of genetic testing. She was lucky enough to be seen at the Mayo Clinic, which offers multiple forms of genetic testing based on the results of our tapestry study. And so based on all of that workup, she was found to have a loss of function mutation in the LAMP2 gene concerning for Danon disease. It was formerly called Danon cardiomyopathy. And because of this, both her son and her sister were subsequently tested and also found to have the same exact mutation. She ultimately underwent a orthotropic heart transplant at the age of 31. However, she struggled with rejection with multiple bouts of hospitalizations, and she very unfortunately passed away a couple of years ago due to complications from her rejection. I actually took care of her multiple times before she passed away, and I just have to say she was one of those patients that you would get a call about in the middle of the night. And initially you'd be sad that she's in the hospital, but you'd be excited to talk to her because she was just an absolute joy to be around. She was also an amazing mother, and all she really cared about, honestly, more than what we told her, was getting back to her son. I simply can't imagine how much her family must miss her. My understanding is that her son had an AICD placed because he was deemed to be at very high risk for sudden cardiac death due to the thickness of his ventricular septum as well as his posterior wall. And I believe this was placed at the age of 8. And follow up, he's doing very well from a cardiac standpoint. However, he's still struggling in school and he has frequent hip and shoulder pains, and this limits his participation in activities. He's also being followed very closely by the pediatric transplant team, and I believe he's under consideration for gene therapy for Danon disease as well.
Wow, I'm really sad to hear that mom passed away. That can only imagine how hard that was for her family and especially for her son. So it looked like our learners were onto something with that cardiac MRI finding. So I think it's time we take a step back and we review Danon disease and put all this together. Srishti, do you want to start us off?
Sure thing, Harrison. Danon disease is a rare X-linked genetic disorder caused by a deficiency in the LAMP2 gene. LAMP2 is a glycoprotein that protects the lysosomes from its roles in endocytosis as well as autophagy. When you have the deficiency of this gene, basically you have buildup of trash inside the cell, and this leads to cardiomyocyte dysfunction and eventually death. Now, unlike many other genetic disorders, this mutation is highly penetrant, meaning most patients that have the mutation will unfortunately also have the phenotype, which is the cardiomyopathy. Now, although there is variability in the age of onset, cardiomyopathy is fairly certain in the future. And this can either be hypertrophic, such as in the case of our patient's son, or it can be dilated, such as in the case of my patient. Also, it seems to be related to preexcitation, which makes sense because, as you'll remember, our patient had preexcitation or WPW on her EKG, for which she received an ablation. And it can also lead to other arrhythmias such as atrial fibrillation, which is unfortunately one of the things that caused her very untimely demise. Now, it's also important to remember that there can be some extra cardiac features as well. And as cardiologists, we need to keep these in mind as well. So the most common things are skeletal myopathy, which could also explain why her son might have been having issues with sports at school, retinopathy, and some very mild cognitive impairment. Given these extra cardiac features, it is best that Danon disease is actually referred to as a disease rather than just a cardiomyopathy.
Thank you so much for that overview, Shrishti. I was reading that previously as that Danon disease was called Danon cardiomyopathy, but as we started to learn more about the extra cardiac manifestations, the name was changed to Danon disease. Of note, the LAMP2 mutation is most abundantly expressed in the skeletal muscle, myocardium, and the brain. And that is why we have this phenotypic expression with skeletal myopathy, retinopathy, and cognitive impairment, as you note. Donnie, can you please tell us about differences between men and women that we might expect?
Yeah, absolutely. So, noticeably, as demonstrated in our cases, there's important differences between sexes in phenotype and patient outcomes. Female patients have attenuated clinical expression due to X chromosome inactivation, and this leads to only partially impaired LAMP2 levels. Whereas affected males only have one X chromosome and therefore tend to present much earlier and with much more severe disease. As we saw with our patients, our baby boy had severe hypertrophic cardiomyopathy very shortly after birth, which is classic for Danon disease in male patients and can also initially be misclassified as the more common sarcomeric hypertrophy. Additionally, male patients tend to experience the extracardiac manifestations of Danon disease, with the skeletal myopathy and cognitive impairment being most common. So just as Pooja mentioned, this is the area of the body where the LAMP gene has the highest level of expression. Nevertheless, cardiac manifestations tend to be the most severe. We see all of this with the patient's son who's struggling in school and has limitations due to his skeletal myopathies. One takeaway we have caring for this family is how important it is to remember cognitive and psychiatric comorbidity that can accompany systemic genetic diseases. It's important to not just consider the heart, but expand to treat the whole patient.
You're absolutely right, Donnie. And especially as we think about taking care of these patients post transplant, those extra cardiac manifestations, for example, skeletal myopathy, have the ability to affect their rehab potential. So it's definitely an important thing to keep in mind.
All right, moving on to some teaching points from mom's case. Female patients will often have later onset of disease manifestations since they have two X chromosomes. So this allows for variable inactivation. But as Shrishti noted, this is a dominant mutation, so there will be some expression, and it's highly penetrant. Their disease manifestations are therefore quite variable, with isolated dilated cardiomyopathy, hypertrophic cardiomyopathy, preexcitation, atrial fibrillation, or even just malignant ventricular arrhythmia that leads to a sudden cardiac death. A good clinical pearl that we gathered, one that harkens back actually to episode 68 with our friends from VCU, when they presented a case of a man with hypertrophic cardiomyopathy and preexcitation, and he was ultimately found to have a PRKAG2 mutation, which has a similar vacuole buildup. When you see that combination of hypertrophic cardiomyopathy and preexcitation, our spidey senses should go up for a non-sarcomeric cause of hypertrophic cardiomyopathy. Another pearl with Danon disease is that the full disease process may not manifest itself until later in life. And this could be after a particularly major stressor, something like pregnancy, as was seen with mom's case. It may even be misdiagnosed as peripartum cardiomyopathy in this setting. There's a recent JACC state-of-the-art review of Danon disease that has a fantastic central illustration that summarizes all of these pearls, and there's also a great table there that summarizes the differential diagnosis of hypertrophic cardiomyopathy that we encourage listeners to check out.
All that being said, longtime listeners of this podcast may remember episode 300 with our friends from Cambridge University, who presented a man in his 40s with dilated cardiomyopathy who was found to have Danon disease. So clearly, these genetic diseases can be sneaky, and they don't necessarily follow the book. As with our patient, she ended up getting this diagnosis after pregnancy, and this led to essentially a family diagnosis, with her entire family now being glued to the local medical system because this disease requires periodic monitoring of all the patients who are found to have this mutation. I think the future of diagnosis and treatment of this disease involves further genetic testing, and it calls our medical community to improve how readily available these genetic tests are to all patients. And I think with improved genetic testing, we could potentially get to the point where we could offer these patients genetic therapy before they display all of these horrific phenotypes.
Wow. Thank you so much, Harrison, Shrishti, and Donny. That was an amazing hike and an amazing pastry. And as we wrap it up here in the Botanical Gardens, I'm really reflecting on how important it is for us to keep a broad differential when it comes to hypertrophic cardiomyopathy and also when it comes to peripartum cardiomyopathy.
And now for the expert CardioNerd perspectives and review segment of this case report episode. We will hear from Dr. Tabitha Moe, one of the adult congenital heart disease physicians in Phoenix, Arizona.
Hi, this is Dr. Tabitha Moe. I'm an adult congenital cardiologist in Phoenix with a faculty appointment to Banner University Medical Center and the University of Arizona and College of Medicine, Phoenix. And today I wanted to share with you some thoughts about Danon cardiomyopathy. Danon cardiomyopathy is a lysosome-associated membrane protein 2 deficiency, which is shortened to, or the acronym for, is LAMP2. The other turn of phrase is glycogen storage disease 2B. This is an association with a pedigree of patients I've had the unique privilege of caring for the last almost 20 years now. This familion is based in Phoenix, and I had the unique opportunity to take care of a patient who then became a mother and her child, and now I get to take care of her cousin as well. This family has been variably affected by LAMP2 or Danon cardiomyopathy. We know that this is an X-linked dominant disorder. In women, it tends to present later and is less likely to have associated neurocognitive findings. In men, it tends to present at younger ages and have more significant disease associations, particularly with neurocognitive diseases. There are some other associated general findings, include a skeletal myopathy, ophthalmic abnormalities, and the age ranges from infancy all the way to adulthood. There is a series of disease groups that have been published over time better identifying these patient disorders. From a diagnostic perspective, if you're suspecting that the patient may have LAMP2. Creatinine kinase can be moderately elevated, but of course is non-diagnostic. The diagnosis is suggested most commonly by muscle biopsy. There are cardiac MRI findings that can be most consistent with LAMP2. A characteristic pathologic feature are the intracytoplasmic vacuoles that contain autophagic material and glycogen and skeletal muscle cells. However, in young children, the vacuoles may not yet be present. Another condition that may be associated is progressive muscle weakness with similar muscle biopsy findings, and a flow cytometry assay for LAMP2 protein expression is also pending further investigation. Unfortunately, there is no specific treatment available for the disorder. Cardiac transplant is the most effective treatment for the cardiomyopathy, which may present either as an infiltrative disease process or a dilated cardiomyopathy process. In patients who are transplanted, there is no indication that retransplantation may be required. There is some association with morbidity related to additional mortality and retransplantation, but that hasn't been able to be proven specifically. Thank you for this opportunity to participate in the CardioNerds podcast. I appreciate your considering me for the role.
Hey everyone, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, then keep on listening, because Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you. So just imagine leaving your office at the same time as your last patient. Now, wouldn't that be delightful? Freed AI is HIPAA compliant, secure, and takes less than 30 seconds to learn. Team, artificial intelligence cannot replace you, but it can do the administrative work that will allow you to spend more quality time with your patients and enhance your personal work-life harmony. So get back to doing what you love, helping your patients, and let Freed AI do the rest. Check out www.getfreed.ai to learn more.